Next, I call upon Dr. KAUSHIK Murali. KAUSHIK Murali is the president of Sankara Institutions in India, and he's going to talk about perioperative antibiotics, oral, topical, intracameral, and NBSS.
Thank you, Dr. Srini, for inviting me to be a part of this IC. It's almost become an annual ritual for us to look at varied topics that interest ophthalmologists across spectrum of clinical care. Okay, it says my time is already up.
No, that's okay. That's okay.
Yeah. So I think it's what Dr. Umesh has alluded to kind of sets up what I wanted to talk about. In terms of perioperative antibiotics, he showed about the dropless surgery where you're having triamcinolone with vancomycin or with moxifloxacin. So there is a tendency for us to use a lot of antibiotics because we are paranoid about infections. When you look at it from a percentage standpoint, it is not too much. We talk about 1 in 10,000 or 6 in 10,000. You talk to an orthopedic surgeon, they probably have a lot more of infections happening. But the way the patient presents to us, and I think the onus that we've put on ourselves in terms of visual outcomes puts pressure on us to make sure that this doesn't happen. There are various causes that have been attributed to infection, right from instruments to solutions to contaminated tissues that have been used. But by and large, most studies have shown that it's the patient's normal flora of the lid and conjunctiva that are the most common source of microorganisms. When we're using prophylactic antibiotics, we need to be careful because you could have toxic and allergic reactions. There is a cost involved. Most times the insurance companies don't cover that. There is an alteration of the protective flora, so you don't know whether you're going to introduce an infection or induce an infection because of your intervention. And always there's a fear of over-medicating and creating some kind of a drug resistance. Again, we don't know the efficacy. Does it change from ethnicity to ethnicity? Most studies have been done in Europe or other parts of the world. Very few studies out of India. That is changing, fortunately, now. And there's a discrepancy between what happens in the lab or what our pharma reps show us and what our own personal experience in the clinic is. Among the organisms that have been isolated across India, most common continue to be the gram-positive species, such as the coagulase-negative staph, the streptococcus, and the staph aureus. Less common are gram-negative, pseudomonas and hemophilus, and rarely you see fungi nocardia. Again, the caveat is certain geographies you would see more of nocardia. I'll come to that. You're more likely to see nocardia probably in Tamil Nadu. That has been our experience across our centers, and we have specific interventions to that. So it's important for you to talk to your colleagues in your city and understand what organisms are commonly seen. Most of them will not publish results, but in a hall like this, just chat with your colleagues around and understand what's happening. Topical antibiotics are preoperatively or perioperative. The evidence is not very compelling. Theoretically, it is supposed to reduce the conjunctival load, but again, there are various reviews that have shown it is not very effective. The ACRS study of 2021 said that in case you're starting off on topical antibiotics, it's better for you to start off a day early rather than on the day of the surgery. So if at all you're looking to start patients, start it a day early. A lot of us during our training period used to give subconjunctival antibiotic and steroids almost as a standard. This is not something new. The first literature that I could find was as old as 1956, where Perlman showed that they looked at subconjunctival antibiotic of about 2 lakh units of penicillin G. But then again, there were various other studies that said that it kind of delayed the onset of infection, and patients are usually lost to follow-up. After about 4 to 6 weeks, they assume that the infection has nothing to do with the surgery, and the outcomes again were very, very poor. Subconjunctival tobramycin has been used very commonly across India. That used to be something that we used to do routinely till a while back, and it was found that it worked very well against protecting against pseudomonas, and it gradually disappeared from the eye after about 8 hours. Systemic antibiotics, again, by themselves probably do not have a role. So again, we come from a system where we used to routinely give doxycycline for 2 days. Again, the premise was that somehow it reduces the lid flora. We found a lot of emotional response in that whenever we put a patient on doxycycline, some strange reason the end-off rates used to be low. And whenever we used to stop reviewing literature, the rates used to go up and we used to go back and start it. Currently, we've stopped it. There is no real benefit of using this because there's very limited ocular penetration. But what they've shown is that wherever intracameral antibiotics are used, if you combine topical antibiotics, probably there is an additive effect. So that again, the Cochrane review has said that this is probably the way it can be used. So if at all you're using systemic antibiotics or topical antibiotics, it should be along with an intracameral drug. Balance salt solution, should you mix anything into it? So Dr. Umesh spoke about the corneal damage that can happen. When you're using anything in a balanced salt solution, there is more repeated exposure to the eye. And again, there is a worry as to what could go on. We don't know how much it really works. They've used various drugs again in the eye, from vancomycin to gentamicin, where comparatively they've compared it with just BSS and shown that the incidence of endophthalmitis is very low. Again, there are studies where they've shown that topical povidone iodine results in low endophthalmitis rates. In ESCRS, again, there was another study where they said that just painting is good enough. You don't need to really look at anything extra. And again, the meta-analysis shows that adding in drugs to your BSS may not be a great idea. Because again, this probably are dependent on your assistant doing it. And when they're injecting a drug, are they even cleaning off the surface? Or are they introducing an organism into the BSS is a bigger concern. So I did mention to you that specifically we've been using amikacin in Tamil Nadu. Both our hospitals, we've been using this because we had a spurt of nocardia that kept happening. So almost about 20% of our endophthalmitis that we were reporting were nocardia species. So again, we did a literature review and we found that amikacin was very effective, between 8 to 16 micrograms. So we took the 2 ml amikacin vial that contains about 250 milligrams, and we took about 0.1 ml and added it to 500 ml of BSS. This results in us getting about 0.02 microgram or 25 microgram per milliliter, which is much more than what has been published. Ever since we've introduced this, we've had almost a zero nocardia endophthalmitis across these centers. So you need to again understand what organisms are there and see whether the antibiotics you're using are actually useful or tweak it a little bit. Now, most of us have moved to corneal incisions and almost scleral corneal incisions. We know that there can be an influx of fluid during the surgery even after hydration. And contamination has been noted in almost about 1/3 of cases. And this is similar both in phaco or manual SICS that we may be doing. So injecting antibiotics intracamerally is intended to kill the bacterial microbes that have been introduced. And there is again enough literature to say that this one-time intervention, you may not be triggering an antibiotic resistance. Again, intracameral, various drugs have been tried. Polymyxin B and neomycin has been discontinued due to toxicity. Payman introduced intracameral gentamicin in a large camp setting in South India, incidentally. This was the first published study to explicitly take culture to confirm. That's the interesting part of the study. But again, they found a lot of false positives. So they don't know whether it was contamination because almost all of them, all the 18 patients miraculously recovered. The largest prospective study was the ECRS study that was first published in 2006, where they showed a significant drop in endophthalmitis with intracameral cefuroxime. Now, various drugs that can be used, cefuroxime, vancomycin, and moxi. Cefuroxime, the fear is with worst outcomes resulting in post-intervention end-off, where commonly Enterobacter has been cultured. Vancomycin, again, there's a fear of hemorrhagic occlusive retinal vasculitis. This has again been reported across the world. Moxi has been pretty good. It has become the mainstay of most intracameral because it is more bactericidal for a much longer period of time compared to cefuroxime. Again, a lot of us use either the off-the-counter Vigamox that is available. Again, no financial interest. Why Vigamox? Because it is unpreserved, so it is much more popular and it is much safer to use. If you're using any other brand, confirm that they don't have preservatives because you don't want to be introducing a preservative into the eye. Intracameral does not prevent gram-negative infection, but however, what has been noticed is wherever it has been reported, the symptoms and signs are much milder than the classical description that you would see with a gram-negative infection. So here again, a short video that shows how we go about mixing it. Typically, we take about 3 ml of the Vigamox that comes, draw it into a syringe that has about 7 ml of balanced salt solution into it. So effectively, the 10 ml of diluted Vigamox that you have has about 15 milligrams of moxifloxacin. And you take about 0.1 ml or draw it again into an insulin syringe, and you would look to inject anywhere between 0.3 to 0.4 ml. Why 0.3 to 0.4? You know your anterior chamber has about 0.4 to 0.5 ml, so you're trying to replace that entire content. Typically, when you're injecting it, you want to inject it in the anterior chamber as well as in front and behind the IOL. This is a video of one of my colleagues injecting it into the anterior chamber through the side port. So most commonly, we would do that. A lot of us who do manual SICS, at the end of the hydration, do inject it through the main section. We've not been able to prove that it remains in the eye, but we believe that because you're injecting 0.4, it flushes out the content and the bacterial load should come down. The other alternative is this technique that we found, where we use a 30 gauge needle and do a stab entry. So where you don't want to really put a side port, or you've not used a side port, we've tried various from 24, 26 and 30 gauge. We found the 30 gauge to be most effective in terms of an ability to seal the wound. So you can directly just stab it in, inject it at the end of the surgery and come out. So it kind of is a self-sealing kind of an incision that happens. So intracameral has come a long way. There are 3 surveys done by the American Society of Cataract Refractive Surgeons, where from about 77% of respondents not injecting intracameral, it has now come to about 83% of them looking at injecting this. So I think it is here to stay. It is a very good tool for us to use as cataract surgeons as a part of a cataract surgery. So once again, thank you, Srini, for inviting me to